Welcome to the Women in AI Research podcast, the show about remarkable contributions of female AI researchers around the globe. I'm your host, Yekaterina, and I'm sharing the mic today with my co-host, Malika. AI doesn't just process text. It takes in our cultures, reflects our hierarchies, and can make existing power structures even stronger. This episode explores how AI reflects society's values, biases, and blind spots across everything from research norms to reproductive health. Okay, let's speak for a while about another topic which is slightly different about AI in health and reproductive health domains. Reproductive and maternal health, to me, it looks like a perfect case study for understanding AI ethics because it sits in the intersection of medical care, social justice, historical trauma, and some very personal experiences. Maria, what do you think this makes this domain particularly revealing about broader challenges in AI ethics?
So I agree with what you just said. And this is an area that I've worked in since the beginning of my PhD. And I've found it to be just a very fruitful area in thinking through many different things. It brings together many different problems. So one reason that we might be interested in maternal and reproductive healthcare in the context of AI is first of all, there's just a long history, not just in my work, but in other people's work in thinking about maternal and reproductive healthcare. There's a lot of prior research and applications of NLP methods focused on maternal healthcare. And one of the reasons for that, and another reason why we might be interested again in this topic, is that pregnancy, childbirth, reproductive health, these are things that touch many, 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 many people. Most people, if we're thinking about reproductive health, most people think about reproductive health at some point in their lives. And also things like pregnancy and childbirth, they might be a person's actually only or their only major interaction with the healthcare system during most of their life. And that means that this is a very significant interaction. It can shape that person's perceptions of healthcare and the healthcare systems. And it also means we have a lot of data and a lot of perspectives and different perspectives on this topic. And then third, yeah, as you were saying, maternal health is this kind of perfect storm of healthcare vulnerabilities. So there are long, horrible historical biases and abuses of birthing people, all kinds of power dynamics that affect care. So, for example, maternal health in the US in recent years has received a lot of attention for high morbidity, mortality of birthing people, and also significant racial inequalities. So, in all these different ways, I think maternal and reproductive health is an important and fruitful site to sit down and think seriously about what would it mean to involve technology and AI specifically in this setting, this high stakes, frequent setting, where we also have a lot of problems and need better solutions.
Interesting. Let's discuss your work, NLP for maternal healthcare perspectives and guiding principles in the age of LLMs. Can you walk us through your methodology and the key principles that came out of this work?
Yeah, so this was a big collaborative paper that I led, again, while at the Allen Institute for AI. So some of the collaborators had more expertise in natural language processing. We had a collaborator, Carla, from the Association of American Medical Colleges, which is a nonprofit, and in particular, their Center for Health Justice. And then also two scholars who have expertise in NLP and machine learning, but also in fairness and accessibility and healthcare. topics. And so we ran a workshop. And so we got a portion of a day in this virtual event to interact with people. We had a group of healthcare workers, maternal healthcare workers, quite a diverse group, racially, all US-based English speaking, but racially diverse, and then diverse across the different types of maternal healthcare work that they do. And we had designed a kind of like demo for them, a kind of wrapper around a chatbot. And we led them through interacting with that chatbot. We let them use it themselves and pose different kinds of maternal health questions for the chatbot based on their experience from their expertise. And then we surveyed them about the different their experiences with this chatbot, their background with AI, like what expertise level they have, their feelings about AI, and what kind of values they think should be prioritized in the design of any technology like this for maternal health. And then we did a follow-up with a group of birthing people who have given birth in the previous 5 years. Same setup, working with the chatbot, survey, ask about values, from all of this, we developed a set of like 9 guiding principles for the use of AI in maternal healthcare. So I'll just quickly run through these. So the first thing was context. Be aware of power dynamics in the care team, know the politics and implications of your measurements, and learn from maternal health traditions and communities. Then the second theme was measurements. So this included optimize for outcomes that support the whole person, protect all groups of birthing people, and hold onto the human, empathy, emotion, relationships, and complexity. And then the last theme was values. Include the voices of those seeking care, always center the agency and autonomy of the birthing person, and respect and support your data sources. And this then was all documented not only in our paper, but in some beautiful artwork that came out of the workshop, and in materials and training materials for the Association for American Medical Colleges and their other like participants and medical professionals.
Amazing work. What did this stakeholder engagement reveal about whose voices are typically centered versus marginalized in healthcare AI development?
So I think, first of all, we don't often see voices at all in this kind of research. In NLP and machine learning. In NLP, we see a lot of work that doesn't ask people or engage with people directly. So that's something that we really wanted to do in this study, was engage with people directly and engage with people, both birthing people and healthcare workers, not one or the other, but both, and try to make one attempt at bringing those different perspectives together, comparing them, and trying to draw insights from both. Because often the maternal healthcare worker context is privileged over the perspectives of the people who are seeking care. And there's reasons for that. So a lot of NLP work focuses, for example, on electronic health records, because that's the text data. If we're doing NLP research, we need big amounts of text data. And where can we find big amounts of text data in healthcare? We can find it in EHR. So a lot of work focuses on EHR, and those are notes traditionally written from the perspective of the healthcare worker, not of the person seeking care. So there are these kind of like structural reasons why the healthcare workers can get privileged. There's also money involved, right? If you can build tools that hospitals will purchase, you'll probably have a better chance at making money than if you are designing things for patients who don't have a lot of money and resources. So again, there can be these structural reasons why that happens. And then there's a lot of work on like social media. That's kind of the other big like text resource. And so there, you can get the perspective of people seeking care, but often without directly speaking to them, only by observing. But here we wanted to talk directly to people.
Mm-hmm. One of the 9 ethical principles that you have listed before, one of them is related to what you just said. It sounds like be aware of power dynamics in the care team. Can you explain how AI systems might accidentally make existing hierarchies worse, even though these systems are designed to be helpful?
Yeah, so there's a long history here. Thinking about this from the US context, just to start, there's a long history about shifting power dynamics in the care team. So, historically, moving from a midwife centered practice of guiding childbirth to then physicians and gender shifts as well in that transition, and giving birth in a hospital setting, to recent interests, for example, in home births, including again midwives and doulas in the birthing process, structural things. So like doulas, there's evidence showing that having a doula is kind of like a birth coach, distinct from like a nurse or a midwife or a clinician. And there's evidence showing that having a doula present at while giving birth in the U.S. Can improve many different kinds of outcomes, from like whether you survive to like how complicated the birth was. And but doulas are not a traditional part now of the kind of like hospital birthing system. Laws can vary around licensing and like access, and this is something people have to seek out on their own, and often have to pay for on their own to have a doula present. So you can think doulas are like a really great way to think about this because they're kind of inside and outside of the healthcare system. They're included but not included, and there's different kinds of like valuations and power hierarchies within the care team, where often like the physician is on top, nurses are below. It's like a literal power hierarchy. And the doula occupies this interesting kind of independent space, and it's something I've explored in some of my prior work, on people's birth narratives and how they write about doulas in the context of their experiences. And so all of this is complicated, historical, fragile, and anything that's introduced to this system could shift things one way or the other. It could improve things. So we have these power problems already. Maybe there's a way to introduce a tool that helps shift things, like shift more power towards the person seeking care. Maybe that's possible. I don't know. But it could also mess things up. So an instinct might be like, oh, we're going to automate the role of this particular healthcare worker. And the choice of which worker to automate could reflect that existing power hierarchy, just as one example of like how things could go wrong in a way that our participants, multiple of them, called out.
You also found that participants worried about AI being used for surveillance of birthing people rather than empowerment. And you noted that much existing NLP research in maternal health focus on data collection and surveillance. What does this pattern tell us about whose interests are actually driving healthcare AI research?
Yeah, and I should shout out here, of course, to Data Feminism by Lauren Klein and Catherine D'Ignazio, which has helped my thinking about power and like the centering of power in these conversations, which is also, I think, part of what's going on here. Who has power to run these studies? Researchers do. There, again, these structural reasons why NLP researchers would look for certain kinds of data. And so, as I said, one of those other sources is social media data. So a lot of prior work in NLP on maternal health has been this kind of surveillance work, like trying to predict whether someone has postpartum depression from their tweets. And I think it's good to step back from that and think about like who asked for this? Did the people with postpartum depression ask for this? Who would it help? Who does it empower? Who is this tool? Who would actually use this tool? Like, would it be used by clinicians to surveil their patients? And then what is the intended use case for this technology? But again, there are these structural reasons why that kind of work exists, which again is like, that's the data we have access to. These are the types of research questions we could possibly answer with that data. And so things get kind of funneled into certain research areas rather than others because the others might be harder. But it doesn't mean they're impossible. They're just harder.
Right. Another principle that you have defined is always center the agency and autonomy of the birthing person. And it seems like this principle contrasts with the reliance on automated decision making in healthcare. How would you suggest designing AI systems that enhance rather than reduce human agency, especially the agency of the birthing person?
This is a really big problem in general, but especially for maternal health care. Again, for historical reasons, there's been a history of, for example, researchers not expecting the agency of birthing people and experimenting on them without full consent. And there's also a history of clinicians making decisions for birthing people, again, without full consent. A lot of this is really horrifying. Again, this is something that I also learned a lot about in my prior work on birth narratives, where people are sharing their personal stories and experiences of what happened to them. And this is something that came up a lot in that study, that the people telling these birth stories, who were recounting their experiences giving birth, they very often frame themselves as having the least amount of power and agency in the situation. Everyone has more power than they do in their perspective. And that's not good. Like that leads to, just to start with, really bad feelings about the experience. And so in terms of like designing systems that like enhance people's agency, again, I would say like things that could possibly shift power back to the person who's seeking care or the person who's giving birth, that gives them more information. So more agency would mean like they need more information, more ability to make decision. We have some new work led by Dustin Wright that I participated in. Dustin led this work on thinking about like epistemic bubbles that models might create. This is something that also already happens in the healthcare context. There's an idea of like epistemic injustice. So who's allowed to know things? And in the most absurd way, like even who's allowed to know things about your own body? When we think about things like pain, which is a really important part of birth, reproductive health in general, communicating about pain is very difficult. It's subjective. So who gets to decide like how bad the pain is and what kind of treatment you should get? Those are hard questions. Like it is genuinely a hard question. It is subjective. We can't get into your brain and like know for sure. But there's also a history there of women, for example, being given less pain treatment than men while reporting the equal levels of pain. So this is one example where this could play out. Any technology that would involve the person seeking care more, that would give them more information, that would open things up for them more, increase transparency about what is happening and what their options are, that seems good to me.
Mm-hmm. I think that again, that's another situation where very specific solutions probably will not work in all the cases. So just those general guidelines of what is important, what to think and have in mind, what to think about are the best that we can have.
Yeah, totally agree. And the last but not the least question I have about this area of research, you emphasize learning from maternal health traditions and communities rather than replacing them with AI. How do we ensure that healthcare AI amplifies rather than displaces existing forms of care, particularly from marginalized groups?
So throughout this section of questions, I keep talking about there's a long history of this, there's a long history of that. And I think it's something that we're not great at in tech and in computer science. We're not trained to think historically often. It's more about like what works now, what data can I get now. And I heard Virginia Eubanks, she is a scholar who studies inequities created by technological systems, especially systems used, for example, by the government. And someone asked her, like, how do we teach computer scientists ethics? And she responded something like, we need to teach them history. And I just agree with that so much. And I find that in my own work, the more that I can understand the history and the bad things that have happened before, and the good thing, in this case, the maternal health traditions and communities that have long existed, people have already found ways to support each other. How can we support that support rather than reinventing the wheel and perhaps messing things up in the process? And how can we avoid the mistakes that researchers and engineers and tech people have made in the past? We're a part of that tradition as tech people, and I find it very practical to think about that history, and to involve people in the work who might know that history better than I do for a particular context.
Right. So I think it's time for us to wrap up. What advice would you give to AI researchers who want to make more ethical choices but are not sure how to get started?
Thanks so much. And also, I want to say, I'm not perfect. I'm also still learning. And some of the work that we talked about today, it's a progression from me doing more of that like social media analysis work to directly speaking to people and like growing in my own skills and understanding. And what I just said about learning history, I think that is really important. It's a lesson I learned from a course that I took also with Karen Levy early in my PhD. Learning about histories of choices, ethical or unethical, made by tech companies in the past. Some of those companies, still exist today, and so learning that history, I think, is a great way to start. And there's so many books. I recommend Virginia Eubanks' work, for example, that I mentioned before. I recommend Data Feminism, which I mentioned before. There's newer books. I haven't read Karen Howe's Empire of AI yet, but I've heard only the best of things, and it's in my shopping cart to purchase and to read. So there's a lot of books. I mentioned Ruha Benjamin's work earlier. She has multiple popular books and also multiple talks recorded and publicly available on the internet for anyone to watch. And she's a very inspiring and engaging speaker, so that would be a great entry point. So many other people, books and researchers and writers who I could shout out here, but that's probably a good reading list to start. And then if you're an NLP, AI, ML person, I think what I would encourage is, I guess, a few things. So one is like, how can you center your work and ground it in something specific? Perhaps something specific that you have personal experience with, that you could actually speak to and understand, that you're designing evaluations, methods, models that actually address something real in a real community. I would suggest trying to collaborate with people from other disciplines rather than reinventing the wheel. Like, bring in a collaborator who has expertise in whatever topic it is that you're studying and work with them in a way that puts their expertise on equal footing with yours. It'll be hard, but you'll learn a lot.
Awesome. Thank you so much, Maria. I will keep these words with myself. How would you teach computer scientists ethics? Tell them about history. That's very nice. Thank you so much for sharing your insights with us today.
Thank you so much for having me.
Thank you, Maria, for joining us today and for this conversation. And to our audience, we're going to share some details and links to Maria's research papers in the description of this video. Check it out and see you next time in 3 weeks.